Welcome to MED-MYSTIFY. Today, we're diving into a fascinating breakdown of how different cholesterol-lowering medications actually function in the body. If you've ever looked at a patient's chart and wondered how these tiny little pills trigger such massive metabolic shifts, well, you're in the exact right place. Let's decode the pharmacology of this explainer.
Today we're unpacking a dense pharmacological table by mapping 6 distinct drug classes into distinct attack vectors against high lipids. We'll kick things off with an intro to the agents, move on to halting production at the source, then blocking absorption and excretion, enhancing breakdown and recycling, and finally wrap it all up with a quick summary of the mechanisms.
All right, let's jump right into Section 1, Intro to Anti-Hyperlipidemic Agents and the Clinical Arsenal.
By definition, all these agents share one overarching goal, right? Managing hyperlipidemia to protect cardiovascular health. They're trying to get those lipid numbers down to mitigate the risks of arterial plaque buildup and heart disease. But, as we'll see, their specific methods of attack vary wildly. When you're dealing with a system as complex as human metabolism, a blunt instrument rarely works. Instead, pharmacology gives us specialized keys for specific locks, targeting various pathways to bring the body back into a healthy equilibrium. It's not just a single magic bullet, it's an entire toolkit we're working with here.
So, this brings us to a really crucial question. Instead of just lowering lipids on a lab test, how do these different tools actually intervene in the body's cholesterol life cycle? You know, our bodies produce, absorb, and recycle cholesterol continuously. It's a highly dynamic, always moving system. To lower the overall levels, we have to intercept that cycle at very specific points. Think of it less as simply bailing water out of a flooded boat, and a lot more like adjusting the plumbing itself to prevent the leak from happening in the first place.
Moving right along to Section 2, Halting Production at the Source. This is our Vector 1.
Our first attack vector focuses on shutting down the problem before it even starts. Essentially, we're turning off the body's internal lipid factory. Here, we can compare 2 major players acting right on the factory floor: statins, which inhibit general cholesterol synthesis, and nicotinic acid derivatives, which we commonly know as niacin, which specifically decrease VLDL synthesis. Both target production, sure, but they go after entirely different assembly lines within your cellular manufacturing plants.
Let's look a bit closer at the most famous class first. Statins inhibit cholesterol synthesis. By directly blocking the enzyme responsible for making cholesterol, statins act as a primary heavy-duty roadblock in the body's internal cholesterol manufacturing process. And here's the cool part. Because the liver can't make as much of its own cholesterol, it's forced to adapt. It essentially pulls circulating cholesterol out of the bloodstream to meet its basic biological needs, which dramatically lowers your overall numbers. It's honestly a brilliant biological trick. Starve the factory so it has to consume the excess product floating around in your blood.
Meanwhile, niacin takes a slightly different approach at the factory level by specifically decreasing the synthesis of very low-density lipoproteins, or VLD. Now, since VLD is a precursor that eventually turns into the dangerous LDL cholesterol in your bloodstream, stopping it right at the source is a highly strategic move. It's kind of like cutting off the supply chain before the final hazardous product can even be built, keeping those overall levels in check from the absolute beginning of the metabolic process.
Okay, Section 3, Blocking Absorption and Increasing Excretion. This brings us to Vector 2.
If halting production isn't quite getting the job done, we move to our second vector. The crucial point here is that these mechanisms deal with the physical movement of cholesterol. They're either actively pushing it out of the body as waste or stopping it from crossing the border into the system in the first place. This is where we shift our focus from factory management directly to border control and waste disposal.
Cholesterol absorption inhibitors, specifically Ezetimibe, act right at the gates. They actively decrease the absorption of cholesterol into your system straight from your small intestine. Think of Ezetimibe as a bouncer at the door, literally just refusing entry to the dietary cholesterol you consume. You might eat a cholesterol-heavy meal, but this medication stands firmly in the doorway of your intestinal lining. Because that dietary cholesterol is blocked, it passes straight through your digestive tract and out of your system entirely instead of ever making it into your blood.
On the flip side of this border control, we have bile acid sequestrants. These work by flushing the system, actively forcing an increase in cholesterol excretion. They do this by binding to bile acids in your gut so they get excreted as waste. Now, since your liver absolutely needs bile acids to digest food, it goes into a slight panic mode when they're suddenly flushed out. So, to manufacture more bile, it's forced to use up the cholesterol currently circulating in your blood. It's another incredibly clever biological workaround that tricks the body into cleaning up its own excess.
Next up is Section 4, Enhancing Breakdown and Receptor Recycling. Vector 3.
Our third vector acts as the ultimate cleanup crew, dealing with lipids that are already stubbornly circulating in the blood. There are two key actions we're looking at here: breaking down what is currently present and recycling cellular receptors to clear out even more. It's really all about optimizing the body's natural cellular machinery to work faster and way more efficiently than it would on its own.
Let's contrast how these two powerful classes work. Fibrates tackle the problem by aggressively increasing triglyceride breakdown, whereas a newer class of drugs, PCSK9 inhibitors, takes a highly specialized molecular route by dramatically increasing LDL receptor recycling. Basically, one acts as an internal shredder, while the other acts as an ever-expanding net.
Looking first at fibrates, these guys serve as the heavy lifters of waste management, specifically increasing the breakdown of triglycerides. As we know, high triglycerides are a major risk factor for cardiovascular disease, often making the blood thick and sluggish. Fibrates effectively turn up the dial on the natural enzymes that chew up and clear these fat particles out of your plasma. They break them down into harmless components long before they can cause any vascular damage.
PCSK9 inhibitors, however, increase the recycling of LDL receptors on the surface of liver cells. Normally, these receptors grab LDL out of the blood and pull it into the liver cell to be destroyed, right? But then the receptor itself gets destroyed in the process. It's a one-and-done mechanism. By inhibiting that destruction, this drug essentially gives the liver more functional, recycled hands to continuously grab and clear LDL cholesterol from the blood over and over again. The clearing efficiency goes completely through the roof.
And finally, Section 5, Summary of Mechanisms. Let's look at the complete picture.
After breaking down these three distinct attack vectors, the factory, the border, and the cleanup crew, let's put the whole pharmacological puzzle back together. From statins inhibiting synthesis to fibrates breaking down triglycerides, sequestrants increasing excretion, Ezetimibe decreasing absorption, Niacin lowering VLDL synthesis, all the way to PCSK9 inhibitors recycling LDL receptors, this perfectly structured toolkit empowers you to understand their precise actions at a single glance, showing exactly how modern medicine tackles high cholesterol from every conceivable angle.
So this leaves us with a pretty provocative thought. Considering all these diverse mechanisms, from the factory to border control to the cleanup crew, which pathway holds the ultimate key for managing hyperlipidemia? Or is the reality that mastering lipid management requires a combination of these vectors, tailored perfectly to the individual patient's biology? It's definitely something to think about the next time you review a lipid panel and consider how best to intervene.
Like, subscribe, and share this with your friends for such more pharmacy-related informative videos. And be sure to write your questions, suggestions, and thoughts in the comment section. We will catch you in the next one.